Greetings, hello, and welcome. Today we'll be talking about trigeminal neuralgia, often called the suicide disease, because of the severity of pain it causes. The trigeminal nerve, or cranial nerve 5, is the largest cranial nerve and carries sensation from the face to the brain. It has 3 branches. Firstly, the ophthalmic branch, V1, covering the forehead, eye, and upper nose. Then secondly, the maxillary branch, V2, supplying the cheek, upper lip, and upper teeth. And lastly, the mandibular branch, V3, carrying sensation from the jaw, lower lip, and also controlling muscles of chewing. What is trigeminal neuralgia? Trigeminal neuralgia, or TN, is a chronic pain disorder where patients experience sudden electric shock-like pain in the distribution of one or more trigeminal branches. Episodes can be triggered by simple activities like touching the face, brushing teeth, chewing, or even speaking. It most commonly affects people over the age of 50 with a female preponderance. While V2 and V3 are commonly involved, V1 is rarely affected. How is it classified? It's important to remember that not all trigeminal neuralgia is equal. So, it is then classified into 3 categories. Firstly is idiopathic, meaning there is no clear cause found. Secondly is the classic trigeminal neuralgia, usually due to blood vessels compressing the nerve root near the brainstem, leading to demyelination and abnormal firing of nerve fibers. And lastly, secondary trigeminal neuralgia. This is caused by an underlying disease such as tumors or multiple sclerosis. What is the pathophysiology? Well, we have the ignition hypothesis, which explains how damaged nerve fibers become hyperexcitable. Instead of transmitting normal signals, they fire excessively and cross-activate neighboring fibers, producing the paroxysmal severe pain. At the molecular level, changes in sodium levels, like NaV 1.3, 1.7, and 1.8, and potassium channels like Kv 7.2, contribute to the abnormal nerve activity. Functional MRI studies even show that trigeminal neuralgia alters brain networks involved in the processing of pain, including the thalamus, somatosensory cortex, and limbic system. So how do we treat it? The first-line treatment is pharmacological. The main drugs are carbamazepine and oxcarbazepine, both anticonvulsants that stabilize nerve activity by blocking sodium channels. They are effective in most patients, but side effects like dizziness, fatigue, and memory problems are common. Alternatives and add-ons include gabapentin, pregabalin, lamotrigine, phenytoin, and other anticonvulsants that reduce nerve excitability. Then we have baclofen, which is a muscle relaxant that enhances inhibitory signals. Then we have botulinum toxin injections. This might reduce pain by blocking neurotransmitter release. We also have newer therapies like eslicarbazepine, an extended release form of oxcarbazepine. Vixotrigine, which is a sodium channel blocker targeting NaV 1.7. Then we have CGRP antagonists and potassium channel openers, which may offer future options. For patients who fail medication or cannot tolerate side effects, surgical approaches are considered. The gold standard is microvascular decompression, where the compressing vessel is separated from the nerve. Other options include gamma knife radiosurgery or percutaneous techniques such as radiofrequency ablation. So, trigeminal neuralgia is one of the most excruciating pain syndromes known to medicine. It arises from abnormal nerve activity, often triggered by vascular compression. First-line management is with anticonvulsants like carbamazepine, but alternative drugs, botulinum toxin, and surgical decompression play critical roles. For medical students, remember, electric shock, facial pain triggered by light touch, and relieved by carbamazepine is the classic clinical pearl. For postgraduates, keep in mind the expanding pharmacological landscape and the need for tailored multidisciplinary management. Thank you for your attention and have a blessed day.